Okay, well, good morning. All right, we're already getting a good turnout. People are going to be drifting in over the course of the morning as well. So it's my great pleasure this morning to introduce Jeremy Smith, who's the author of a new book, Epic Measures, One Doctor, 7 Billion Patients, the true story of a 20-year, 500 scientists, $100 million moonshot attempt to track and quantify every illness, injury, and death for everyone on Earth. The biggest of big data ever. He writes regularly on health for the New York Times, The Atlantic, and Discover, and he and his work have been featured by CNN, NPR News, and Wired, among many other outlets. His first book, Growing a Garden City, was one of the book list's top 10 books of 2011. He lives here in Missoula, and we welcome him here to speak to us. Good morning.
Thank you. Well, I'm really happy to be here. Thank you so much for coming out and tuning in, if you're tuning in. I want to get a quick sense of the room, and then I'll get right into it. So who here is a doctor or nurse? Okay. Who is on the sort of public health side of things, if anyone? And okay, so about 2/3, maybe 1/3 with some overlap. Could you raise your hand if you are a policymaker in some way, if you're deciding kind of where, or have been, if you're deciding kind of where to direct resources for investments or staffing? 1, okay, or 2, I think. And could you raise your hand if you've ever worked internationally in some kind of medical volunteer capacity, which could include even just clean water campaigns. Okay, about half of us. Kind of a personal question, but I won't get into the details. Could you raise your hand if you have ever, well, I guess I'll ask another question first. Have you ever donated to any kind of relief effort of some kind of medical aid work of some kind? Okay, about 90% of us. And have you ever had someone you cared about who was sick and you were not sure that they would get the care that they needed? About half of us. Well, I think this will be a relevant talk for you, and I will try to keep it at a pretty good pace so we can get into your questions and comments. I'm going to start with a pretty big global perspective, come back to the United States, and then end up here in Missoula. So Epic Measures is the story of the origins and impact of the Global Burden of Disease Study, which is, as you heard, a 20-year, 500 scientists, $100 million effort to create the equivalent of Google Earth for health, where you can survey an entire continent like Africa and see what's killing people and making them sick. You can zoom into a particular country like Italy or Afghanistan, or an age group like children or the elderly, or men or women. And where you have even more data, such as in the United States, you can go all the way down to, say, a county level, or in some cases even a zip code level. So we'll sort of explore what you see in that way. And why would you need that, we'll get into as well, but the basic reason you want to know what's killing people and making them sick is akin to the medical adage, first diagnose, then prescribe. First know what people are hurting from before you try to solve their problems, or you may be missing some pretty big problems. So why? Why do we need this? Why would something so simple as matching our efforts that we're putting forth to prevent, diagnose, treat, why would that require 20 years, 500 scientists, $100 million? Aren't we doing that already? And I'm going to sort of explore what has been the world in the absence of the Global Burden of Disease Study and what is our picture with it. And I'm going to do that with sort of 3 basic questions. And the first 2 questions, fair warning, have kind of scary and to me somewhat depressing answers. And the last one has a little bit of a happier ending, so I'll get you to a good place by the end, and then we'll talk about Missoula. So, question number 1, what is the scientific evidence base for health policy? What is the information we use to make decisions about how we spend our time and money and direct our efforts? Well, big picture, globally, this year, about 50 million people will die around the world. Of that number, only 1 in 3 will have a death certificate. Putting aside the accuracy of death certificates, which I'm happy to talk about in the Q&A, that means 2/3 of deaths go unrecorded. So how on earth can you save lives if you don't know what people are dying from? In the absence of that information, what we have is usually single issue groups devoted to a particular disease or place or people. So for example, you have the AIDS people measuring who dies of AIDS. You have the malaria people measuring who dies of malaria. You have UNICEF counting child deaths just in case they screw it up. You've got Save the Children watching their back. Here in the United States, we've got people looking after lung diseases. We've got people looking after drunk driving. We've got, of course, the famous pink ribbon for breast cancer and other less well-known other colored ribbons. For example, the purple ribbon for Alzheimer's awareness. And then in the event of natural disaster or other emergencies, you have groups that kind of coalesce and appear overnight almost, such as after the 2010 Haitian earthquake, the 2011 Japanese earthquake and tsunami, and just this year in Nepal. So these are very important groups. They're doing wonderful, vital work, but there's a problem with the way they measure things. Are they using the same methods to measure who's dying of their particular causes? Are they comparing their numbers with one another so they can have the most full and rich picture possible? And sort of most dire of all, are they conflicted in their roles? Because all of these groups have dual roles as measurers, but also, and perhaps even foremost, as advocates for the particular cause they study. And when you are an advocate, if you have a range of possible estimates, you're probably going to lean on the larger number of people dying from the particular cause you're advocating for, because that was more likely to rally money and attention to your cause. So, as an example of this, in the 1980s, the international health community was focused almost exclusively on child survival, focusing on diseases that kill children at a very early age, getting them to live past their 5th birthday. So at the World Health Organization in Geneva, you had a group studying children dying of diarrheal diseases. You had a group studying children dying of pneumonia, a group studying children dying of malaria, and a group studying children dying of measles. These people were all under the same big building in Geneva, but they were in separate offices, and each produced an estimate of the number of children said to be dying of that particular cause. These scientists, who would go on to found the Global Burden of Disease Study, did a very simple calculation. They took those 4 numbers, how many kids die of A, B, C, and D, and they added them up. When they did that, they found that that sum was 10 million children greater than the total number of children who died from all causes. Okay? So, from just those 4 causes, the World Health Organization, the leading global authority on health, had invented 10 million extra children who were dying. Okay? And the problem was actually more dire than that, because children, even in poor countries, don't just die of 4 things. There are hundreds of things which could kill a child, and leading things that kill many, tens of thousands, hundreds of thousands of children, even in very poor countries, include congenital anomalies. That was not being counted. Cancers, not being counted. Birth trauma, not being counted. Fires, falls, drowning, car crashes. All of these are major killers of children, even in poor countries, and those were not being counted. So you had massive overcounting on one hand, and you had undercounting on the other hand. And maybe the most striking example to me of undercounting is the example of tuberculosis. Tuberculosis in 1990 is later estimated to be killing about 2.5 million people a year around the world. Used to be one of the leading killers in wealthy countries as well, responsible for as many as 1 in 10 deaths in the United States and Europe a century ago. Largely tamed, but still a major killer, especially in the developing world, killing 2.5 million people a year. But those people were largely not children. Okay? The leading victims of TB were adults in their 20s and 30s. Caregivers for those children, providers for the elderly, but because they were not children, they were not being counted. They were not being comprehensively studied, and there was no comprehensive treatment to deal with them. So, for example, at this time period, at the World Health Organization, there was exactly 1 person working on tuberculosis. Okay? The leading infectious disease killer of adults had 1 person working on it at the World Health Organization. Okay, here in Missoula County, you would know better than me, but last time I looked, I think we've got at least someone doing 3/4 time. If we add up a few different roles working on TB. Missoula, we've got 1 person-ish. The world had 1 person for the leading infectious disease killer of adults. What an amazing mismatch. And I don't want to just pick on WHO. The Institute of Medicine in Washington, D.C. surveyed their staff, their experts, their eminent physicians, and said, what should be our priorities for international infectious disease research and treatment? And they wanted them to rate them in terms of highest priority, medium priority, lowest priority in this time period. I would like you to guess what priority they rated TB, the leading infectious disease killer of adults. Lowest, 6th, something. It, in fact, was not ranked. Okay? By point of comparison, leprosy was ranked as a medium or highest priority cause. Okay? So, just to give you a sense of what was at play. And the medical doctor, economist, and epidemiologist working together to go on to co-found the Global Burden of Disease study did a pretty simple calculation because effective, fairly inexpensive treatment exists for TB, even in this time. And we could talk about that in the Q&A too, but they calculated, just a sort of back in the envelope way, that globally, to treat all new cases of TB in $1990 would cost about $700 million. By point of comparison, to not treat these cases of TB and just deal with the repercussions would cost about $4.1 billion in the United States alone, because of about 20,000 people infected largely in New York City and other major urban areas. So, $700 million to deal with it worldwide, or $4.1 billion to deal with it just in the US. That was a compelling argument. And to this global picture was added TB campaigns, okay? World TB Day, and more recently the multi-billion-dollar global fund to fight AIDS, tuberculosis, and malaria. There's TB hiding in the middle. And that's great. But the problem with that method of dealing with the health problems people have is you'll always be about a generation behind your efforts by what the issues people are facing. Today, I don't want to just pick on the 80s or the 90s. Let's go right here to 2015. Okay? Today, if you live in a poor country, in a developing country, the most common, the most likely thing that will kill you is exactly what kills people in the United States, is non-communicable diseases, chronic diseases, so-called lifestyle diseases, heart disease, stroke, diabetes, cancer, okay? Those are responsible for 64% of deaths in developing countries, okay? About 2/3 of deaths in poor countries are from non-communicable diseases. I would like you to guess what percentage of medical aid money, which is almost always earmarked to a very specific cause, goes to deal with the killers of 64% of people in poor countries. We've got some real cynics in the crowd. Okay, 0, 10, 25, I don't know. In fact, you will see that this number is in the front page, page 1 of today's Missoulian. I was like, wow, synchronicity. But 64% of deaths causes of 64% of deaths are last accounting, which is, lags a couple years behind, but is 1.2%. Now, does that mean funding should always be exactly matched to the causes of death? People have different, costs of intervention and so forth, but maybe, maybe not. But that is quite a mismatch today in 2015 between 64% and 1.2%. So that's kind of where health policy is and where the evidence is. I want to go to question number 2 now. Are we measuring the right thing? Okay, putting aside all that I've said, is death the thing that we want to be tracking? Is death what we want to be combating? It would seem so, right? We want to save lives, so wouldn't you want to prevent death? But I want to just explore maybe, maybe not. Okay? So, for example, globally this year, about 6 million people will die of stroke. By comparison, only about 300,000 will die of meningitis. So is stroke 20 times worse a global health issue than meningitis? Maybe, maybe not. Something to know before we answer that question, or something to consider, is that the average person who dies of stroke is age 75 or older. The average person who dies of meningitis is a child under the age of 5. Is there some way to capture that information in our comparisons so we can kind of understand the distinctions between those two kinds of deaths, if we want to? Well, there is this metric, years of life lost. Okay, years of life lost is very simple. It says, how long do people live on average in the longest living places in the world? Somewhere like Sweden or Japan. And they live about 85 years on average. So basically they say, that's our ideal. If you fall short of that ideal, you've lost that many potential years of life against that ideal. So, for example, if you die of stroke at the age of 75, how far are you off that 85-year ideal? 10. So you'd have 10 years of potential life lost by that metric. So you die of meningitis at age 5. How far are you off that 85-year ideal?
87.
Yeah, 80. So by that particular metric, a death of meningitis at age 5 is 8 times worse than a death of stroke at age 75. So just something to sort of have in our heads as we're kind of considering this. But we're still missing something really big. We're in fact missing the biggest reasons people go to seek medical care. The biggest drivers by far of health costs and rising health costs. And the biggest causes of pain and suffering. In other words, we're missing everything that does not kill you. If you are blind, if you are deaf, if you are anxious, if you are depressed, if you are disabled, if you are disfigured, if you are simply sick, those are non-fatal conditions, and they will not show up in any measurement, however perfect, even if it's perfect, of death or of years of life lost. But those are really important issues, as you all know from your sort of work, right? Every time, the way I put it when I'm talking to other people is, every time you go to the doctor and don't die afterwards, you're sort of showing what's missing when we just measured that. So how do we get those into our measurements too? Well, the scientists behind the Global Burden of Disease study have introduced this metric, years lived with disability. And this is a little bit complicated to calculate, and I can get into details, but in short, they take an international survey of people around the world, asking them to rate the severity of different conditions. They also ask experts in particular causes. And they basically say your years lived with disability is how bad the health problem is, the severity, times how long you have it, the duration. Okay? So you get how bad it is times how long you have it, and that gives you your years lived with disability. And what's nice about this is it can be compared directly to those years of life lost. On the one hand, you have quantity of life lost, to a particular death, YLLs, you have quality of life lost, if you will, years lived with disability, and when you add those two figures up by cause, you have total years of healthy life lost. But because this is medicine, it's peer-reviewed science, it's big data, you have to have a horrible acronym for it. So instead of calling it total years of healthy life lost or healthies or something that would be nice, people have to write a book about this kind of stuff, they're called DALYs or disability adjusted life years. But all that means is total years of healthy life lost. So what is the perspective we get from DALYs as opposed to deaths? Well, let's take a look. Top 10 causes of death in the US in 2010 according to the Global Burden of Disease study. Top 10 causes of DALYs in the US in 2010. And I want to just put the differences between those two in bold so we can see them more clearly. Low back pain, major depressive disorder, other bone and joint pain, road injury, drug use disorders, neck pain. So low back pain, major depressive disorder, other musculoskeletal disorders, neck pain, for example. Those kill no one directly, okay? 0 deaths, but they affect millions of Americans quite severely for very long periods of time. And so by this particular accounting, they are way up on this list. And road injury is an interesting example too. Road injury does kill many people, although numbers have declined quite a bit in the United States. But road injury also doesn't kill lots of people, but horribly disables them for long periods of time. And so you have a mix of, and the most people who die of road injury, the leading victims are in their 20s and 30s too. Teens, 20s, 30s are the leading sort of deaths. So you have both a lot of years of life lost by dying quite early for the average victim, and you also have many years lived with disability for the consequences. So that's sort of an interesting mix of the two. I want to look at number 11 too, neck pain. This is something that is, so dismissed that we have this expression. It's like a pain in the neck. But it's such a major cause of pain and suffering in the United States. By the DALY metric, it's about 80% more dire in its toll than breast cancer. And, I say this with no particular glee. My mother is a breast cancer survivor, for example. But I just think about how many products and races and, campaigns are for breast cancer. And there's no ribbon, there's no advocates that I know of for neck pain. Then NFL, the National Football League, dresses up in pink for a week. They don't even care about neck pain. It just suggests sort of areas that are really underaddressed, even here in the United States, for sort of attention, funding, treatment. And people are suffering in large numbers. Why don't we have early detection of depression in the way we do for stroke, right? Why are we not trying to prevent low back pain as aggressively as lung cancer? It's in part because it hasn't been on the list. This is a way that, it's not formed, this list is not made by advocates for those causes, but it suggests a mismatch. So, question number 3. If we use new evidence and new measures, how far and how fast can we improve? What would happen if we took this evidence seriously? What would happen if we tried buying into this new way of looking at health? Well, a couple examples. Mexico was one of the earliest adopters of the burden of disease approach. The Minister of Health in Mexico saw the first global burden of disease study, said, I want this done at a national level for Mexico so I can see what's going on throughout the country. And what they found was not unlike what I just showed for the global picture. The Mexican health system was built for the health problems of 1 or 2 generations before. It was built around infectious diseases. It was built around women dying in childbirth, and those numbers were way down. Now chronic diseases like heart disease were, was the leading killer in Mexico. Diabetes was epidemic. Car crashes were a major cause of death. AIDS was now on the horizon. It hadn't been, obviously, in the 1950s and 60s. And meanwhile, people had arthritis. They had back pain. They were depressed. You had children who were suffering from cancers that had not been measured on the previous. And so they used this, and meanwhile, you had a situation just like in the United States where 50 million people were excluded from medical care altogether effectively because they lacked insurance. They were self-employed or unemployed. So they were outside the medical system. So seeing these enormous mismatches drove major reforms in Mexico. They decided to redirect their health system to address the problems people actually had, prioritizing those investments that were the most, had the greatest toll to the population. Shouldn't sound so radical, match solution to your problems, but it kind of was. And remarkably, this was a story that was completely unknown to me, at least when I started writing this book. Mexico, in a less than 10-year period, moved to a form of universal health care. And they were able to find the political consensus, the financial consensus, make the right investments based on following this kind of evidence. So there is a country in North America in the last decade that achieved a form of universal health care. It just happens that that country is Mexico. But as you all know, universal health care is not magic. It is still money being paid for particular things. You cannot just magically treat everyone for everything everywhere. You still have to know where to direct those investments. So I want to look at the example of Australia. Australia already had a single payer system covering their population, and they used their own national burden of disease study to try to direct where should we invest our public health investments. Okay, so we can try to catch these issues before they, get to a hospital setting, for example. And Australia is an interesting case because it's a country demographically not that different from the United States. Much smaller, of course, it's 10th the size population. But a generation or two ago, Australia and the United States, there are about 40 wealthy countries in the world. And Australia and the United States, about 1 or 2 generations ago, were right in the middle in terms of life expectancy. They were both around 20. Australia has made these investments targeting specific populations with the specific problems that they saw with the global burden of with their national burden of disease study, and they've seen extraordinary results. Life expectancy in Australia for men is now larger. As if you are a boy born today in Australia, you are expected to live longer than a boy born in Japan. They're about first or second in the world. Women are in the top 5 or 6. In that same period, the United States has fallen to just about last among wealthy Western countries. We're about 40. So that shows that you can start at the same place, make different decisions, and end up with different outcomes. And I do think following that evidence has been one of the drivers of Australia's success. And I don't want to just pick on the United States. The United States also has huge success stories. Here, for example, is New York City's life expectancy chart. New York City has had these crazy mayors that have had these insane tyrannical efforts that were to do early detection and treatment of TB, then AIDS, they had this just bizarre and aberrant plan to make smoking illegal in public places, 10 years ago, and this was crazy. We all were like, this, great, but it's crazy. And, when I moved here to Missoula, it was legal to drink and drive, right? We were like, the driver could be drinking. You just could not be drunk, okay? That has changed. But even, it's amazing. In Montana, you can't smoke in a bar. These things that are just bizarre and so impossible to achieve, and only in New York, and he'll be voted out, become just something we don't even question. And, even in Russia, smoking is banned now and stuff. So these spread around the world. So I want to just say that with a little drama just to show that these things that we think are stuck this way can change. And they can change really quickly. And New York, of course, has had these more recent issues with soda taxes. Mexico has a tax on soda, as does Berkeley, California. And now, the new mayor of New York's big campaign is to zero out traffic-related fatalities. Okay? So if you are a child born in New York City today, you are expected to live 10 years longer than your parents were, okay, generation. So if everywhere in the United States had the same gains as New York City, we would not be 40th, we would be the longest living country in the world, we'd be ahead of Japan and anywhere else, okay? So big gains are possible, and not just in New York. Here's a map of the United States colored by life expectancy. We have so many countries within the United States, okay? If you look at the places in dark blue, those are places where you are living as long or longer than Switzerland or Japan. If you look at the places in dark red, you're living more along the lines of Syria or Panama, okay? It is a 10-year plus difference between those counties. They're colored by county. And, you know, at an individual population level within counties, between the longest living group in a particular county and the shortest living group, the difference is greater than that between Switzerland and Somalia. Okay, so if you see this data, you can see where these gaps are, who's thriving, who's suffering, and then maybe dig into why. I want to get to Missoula before we get to questions, but I want to show one more chart. The thing I want to flag, this is change in life expectancy, and the part I want to sort of flag for women between 1985 and 2010 is I want to look at counties in dark red. Dark red that's a third of U.S. counties are places where life expectancy for women has declined in the last generation. This is the first time that has ever happened in the United States in the absence of an accompanying war or infectious disease epidemic. So if you are a little girl born today in one of those counties, you're expected to live less long than your mom. And that's a really scary thing. So what's happening here at home, right? What's happening in Missoula County? Well, the most common explanation for these differences within the United States is money. Okay, if you're rich, you live long, you do great. If you're poor, you're screwed. And maybe not. Okay, that's a contributing factor for sure, but it's not the only factor. And I want to just explore with the example of Missoula. So Missoula County, if we look at our poverty levels, we're in the middle. We're right at the national average, middle 50%. So if money was the sole driver of health outcomes, we would expect that our life expectancy would also be right at the U.S. average. And maybe it is, maybe it isn't. But let's look at some other things under the hood. How are we doing in terms of smoking? Well, we're actually doing well for men. We're in the best 10% of all counties for men. And we're doing okay, but not great. On the best 25% of all counties for women. How are we doing in terms of obesity, major driver of the ailments that are rising most rapidly in the United States? Again, we're doing pretty well. We're in the best 10% of all counties for men and for women, so that's really good. Physical activity. Okay, who else spiked here this morning? We're in the best 10% of all counties for men and women. So wow, we are awesome. It's just gonna. Okay. So prevalence of heavy drinking. Well, let's see. Okay, we're in the worst 10% of all U.S. counties for women, and we're in the worst 25% of all U.S. counties for men. And men, do not be too proud, because men, of course, drink much more than women. This probably just means we're a sort of state or a county where women and men are kind of equal. Okay? It doesn't mean women are drinking more than men, but compared to their female peers. So that's not good. Binge drinking. And of course, this is not just cirrhosis, as you all know. It's causing these car accidents. It's causing intimate partner violence. It's driving suicide. It's driving self-harm, fires and falls, among many other things. We're in the worst 10% again for women, and we're in the worst 25% for men. So what's this going to be, okay? And there are other factors involved, of course, but I show this stuff just to say we need to know not just what our outcomes are, but we need to know what's driving those outcomes. Because in the absence of that information, You might not know what you're doing well, and you might stop doing it, okay? You might not know what you're doing poorly, and you might keep doing it. And, you've got to be able to borrow ideas from other people and compare other ways to sort of understand what gives you those outcomes. So let's take a look. How are we for life expectancy? Are we right at 50%? Are we 25? Who knows? What's driving what? All right, we're in the best 25%. So we're not in that 10%, which some of those early numbers would have said, and maybe alcohol is something that's dragging that down. Maybe poverty is dragging that down, okay? But we want to understand an interplay. I can't answer definitively, of course, but as we get more information, it lets us make comparisons. And here, for example, is the US Health Map tool. Well, I'll show you this. All this stuff you can pull up on your phone instantly now, whatever. It's all live, and we'll talk about that in a minute. But here, for example, I clicked on Missoula County. You can see it outlined on the map, but it shows the life expectancy trends in Missoula County. And also it shows, and you can tabel men, women, and so forth. But it also shows where we are against the state and national average, which are pretty similar, the dotted line and the straight and the solid line. And it also just shows all the other counties in Montana. So those counties that are taller than us, are those just richer places? Or are they doing something we're not? And they got alcohol under a little bit better control, perhaps. These places that are way lower, I wouldn't be surprised if this crowd guessed some of those places, but I think there would also be some surprises in there. Are they just poorer than we are, or is there other things going on? So it lets you sort of dare to compare with your neighbors and look at under their hoods too, and sort of see if they've got ideas you can borrow and so forth. So I want to close and then sort of invite discussion, and also I can show you, we can play with these tools if you want. I'm excited because we're moving to a world where this stuff is just available. You can pull up this US Health Map anytime. It's just a web tool. Anyone can use it. Same thing with this. This is where I pulled that top 10 list. And I could switch from the United States to the world or any other country. I could switch the age group to just children under the age of 5, or just a group that's near and dear to my heart, which is men in the United States between the age of 35 and 39. Focus all of your efforts on that. I've got a wife, I've got a niece, anyway, I've got a few other groups I care about. You can switch some women. You can switch from DALYs. Say maybe you don't buy that. You want just death. Or you're like, I only care about disability. You can switch to just years of disability. You could also switch from causes to risks, because they're also studying the risk factors, like smoking or obesity or diet-related issues or alcohol consumption or air pollution that are driving these causes. And in some, I'm excited. We're going from a world where I think it's akin to 500 years ago when the first maps of the world were created. And the absence of those maps, we didn't know where we didn't know what the continents looked like. We didn't know where one country was relative to another, or the different sizes, or the routes between them. And we relied on sort of courtiers and spies and whispers and rumors, a landscape not unlike this one. And we're going to a world that looks a little bit more like this. This is a map of global health. In terms of DALYs, the bigger the box, the greater the percentage of DALYs to that particular cause. And you can mouse over them, and it's, IHD is ischemic heart disease, MDD is major depressive disorder, and the causes in blue are non-communicable diseases. The causes in red are infectious diseases and nutritional disorders and problems related to childbirth. And the causes in green, another hugely neglected category in terms of global health, are injuries. The darker the box, the more it has increased in severity in the last 5 years in this particular chart. So what I like about this, it's not necessarily perfect. We're moving from our 1492 map to our 1592 map to our 1992 map to hopefully catching up where we have more data to a kind of Google Earth map. But we have we have diarrheal diseases, but we also have TB. Okay, we have breast cancer, but we also have low back pain and neck pain. So you can sort of see your landscape all at once, and you're not sort of siloed in your perspective. You can play with these tools at healthdata.org. I've got a web browser, we can pull it up too. There's a lot more. You can read more about EPIC measures and see some of the ways I've explored this in my journalism. At my website, jeremynsmith.com, there's postcards too for the book in the back. And that's it. Thank you so much. I'd love to hear your insights, your questions. Thank you.
Use the microphone.
Not too long ago, we were led to believe that our children would not live as long as we would, that our generation, older generation, we're going to do best. Has this disproven that?
It depends who you are and where you live, right? I mean, what this shows is that there's a great variegation, especially in the United States. So you can live in counties like New York where if you're, I have a 5-year-old, so, where, on average, my kid would be expected to have 10 years longer than I would, and my wife's from Mississippi, and there's a lot of that stretch. If we go to Neshoba County, Mississippi, I'm going to pretty strongly guess that you would say on average a little girl born to a daughter there would have a lower life expectancy. And so, that's an answer to your question. Life expectancy, of course, is a funny metric. It's a projection. It's based on current health conditions. It's, projection. So, but it's still a very important one and one we use to make our planning decisions. So that's one answer.
You may have, can you hear me? You may have alluded to this, or maybe I was hoping you were alluding to it, but the example of Australia making those dramatic changes in Mexico, it strikes me that the one real huge difference is universal health care, the universal access. And in terms of your hopeful message, which is this can change quickly, is this effort, do you think this effort, have you seen any evidence that it is affecting our public policy here in the United States, either at the federal or the state level? I think the federal is more important. To me, if we don't have a single payer system with universal health care, the chance we're going to be able to use this data effectively is really low. So I just want your thoughts on that.
Well, let me answer the general question and then the specific question, even though you asked in the reverse order. I think it goes both ways. If you show the evidence and you say, this is how I'm going to invest the public money, and this is the mismatches, I think that helps make the case for public investment in a single payer or other kind of universal health system. In the absence of using that evidence, you're left with the vulnerabilities that healthcare costs will just keep skyrocketing because it's not magic. It's a single payer isn't just great. You'll just show up with whatever problem you have and we'll just treat it perfectly, right? So I think that was part of the drive in Mexico is they gathered the evidence and they made the case and they made the plan and they showed the mismatches, and that directed the investment. And in Australia, they already have the system, and every country that has that system has no plans to give it up. So I think that strongly supports, your statement. But again, can they deal with the rising costs? Or are they going to have to ration, in other ways? Or are they allocating their money as effectively as possible if they're trying to help as many people as possible? But even at a private system, even at a hospital system, to understand, what you see when you get this picture over and over again is, gosh, we're putting, often in the beginning before you have this data, we're putting 90% of our resources into 10% of our problems sometimes, and we're not even aware of 50% of our problems. At a population level, you also see, 10% of our population may have 50% of our burden of disease. So Australia, for example, did a follow-up to their national burden of disease study, looking at Aboriginal and Torres Strait Islander health, the equivalent of Native American health. And they looked just at that particular population, and what they saw that Australia had these extraordinary outcomes but that population had very poor outcomes. And 1/3, Native men in Australia were expected to die before they were 60. And that's part of their national average. So it shows even if you're #1 in the world for men, you might actually still have low-hanging fruit, if you will, that can keep driving improvements. And we're a population that's still not served, but is lost in that average. So as to buy-in in the U.S., yeah, this stuff was published in, I talk about it in the book, but yeah, it's published in JAMA, published in the New England Journal of Medicine, and Michelle Obama had these scientists to the White House for a big policy summit about the sort of figuring out the risk factors. Is diet or exercise most important, for example? How do you figure out where to direct even investments between those two areas? Whatever the money you have. And even in very poor countries such as Rwanda, the Minister of Health looked at their risk factors. What was the leading risk factor for health loss in this very poor country? And it was not, malnutrition. It was not outdoor air pollution. It was not alcohol. It was not unsafe birthing conditions. In their case, it was something that just had not been on their radar in a major way. It was indoor air pollution from dirty cook stoves. And this is a cause that is known in global health, but has much less support, attention, and effort as, for example, the cause of clean water and sanitation, which by their analysis is maybe 1/5 the total of this indoor air pollution. And they did a kind of cash for clunkers program where they swapped out 100,000 dirty cook stoves for clean cook stoves. So whatever your system, if it's a national system, single payer system, private system, struggling government or aid agency, Gates Foundation uses this data a lot. It helps you sort of figure out how to direct the resources.
So with your the Valley data,
Yeah.
I was wondering how do you calculate it, like kind of your dollar on dollar return, like when you're trying to treat something like heart disease. I guess there's everything from like the just aspirin a day, like high cost procedures, but how do you I imagine if you're treating tuberculosis, you treat them and then say they're done and it's over.
So cost benefit an hour of different interventions. So it gets tricky, right? But you do, and Australia did this too, because they had this exact situation where what interventions are they going to pay for? Are they going to pay for antidepressants? Are they going to pay for short-term therapy? Are they going to pay for screenings for, colorectal cancer? Or does that cause more harm than good? And they did these kind of interventions, and they did say, this is what it costs. This is the number of DALYs it prevents. And you don't always need to choose the biggest value, but you at least want things that give you a positive value. And sometimes you have huge mismatches. You see that in international aid too. You might have countries that have a much greater burden of disease getting many fewer aid dollars. Or you might have causes that kill many fewer people or injure fewer people that have a lion's share of the money because they have the advocacy for it.
To build on that remark, it seems like there are some interventions that address problems that are not on your list right now, like, for example, cervical cancer, not a huge cause of DALYs right now, but if we weren't spending a lot of time and money doing screening for that, might it become one? And then how do you identify those sorts of things?
Yeah, what's the cost of not doing something? Right, you don't want to be bound by part of the reason that infectious diseases are much less of a toll in developing countries is because we've made major investments in infectious diseases. So how do you keep up your successes and not sort of backslide? And this is part of the push me pull you, and this is why these things need to be regularly, routinely, updated. So you don't have a picture of the world once every 20 years, but you have something where they're giving you this kind of feedback and data every year, ideally, and even faster if you have a tighter setting, a hospital setting. So, just an analogy would be to crime, right? If you address crime in an area and it is then safe, do you then stop policing that area? So I think that's an on-the-ground question that, you don't want to sort of just be completely in a classroom setting, making academic things that ignore the consequences of not doing it. And I don't think they are.
Most of what you're addressing are the impacts of public health measures on disease burden. And we all know that back in 1900, that was a huge determinant of why lifespans are longer now. And I'm really, I guess, speaking for this country, because we spend this huge amount of money on hospital-based, intervention-based, individual-based things rather than public health. Does this study help capture the benefits of that, especially for the, the 10% of the elderly that cost so much and things like that?
I think it's a mode of thinking that can apply to sort of any, issue where you're trying to figure out how do I get a bigger picture perspective. And where they have the data or they have these visualizations, you can dive into it and look at, where are our costs, or where are they focused and so on. Interestingly, Mexico, China, the United Kingdom, the Kingdom of Saudi Arabia, and now India have all made investments to receive this data on a routine basis at a province or county level as it's updated. They are sharing the data and they are spending money to get it at that level so they can sort of make those kinds of trackings. The United States hasn't done it at that level yet, so it's sort of catch as you can. There are pilot projects through the CDC in King County, Seattle. Coordinating institution for all this work is the Institute for Health Metrics and Evaluation at the University of Washington in Seattle. And so in King County, Seattle, in Fulton County, Georgia, not coincidentally, where the CDC is, and I believe in New York City, they're going to do a zip code +5, in other words, extended zip code level of some of the analyses I just showed you. So that means basically a 5-block radius. And so you can really start to see where you're concentrated. And for the early data I've seen on King County is in the top 10% for US health outcomes. But within King County, you see that same 20-year Switzerland to Somalia gap between neighborhood pockets. So you can be the top 10% and still have areas where you're equivalent, in Somalia. And if you can address that, you can be in the top 1% or even better. So I'm not making the question, but I'll
I guess my question is more of a was this addressed? Because to me, when I hear about the 1 doctor, 7 billion patients and all those medical problems, primary care is the first thing that comes to mind. So I don't know if this was brought up in any manner, because I think one of the differences between countries that have a single payer is the monetary value they place on primary care compared to the United States. Not the actual value, but the reimbursement value, and the fact that we have massive shortages because in the United States, the payer system is so poor for primary care, and yet they're the people dealing with the back pain, the depression, the congestive heart failure, and all of those things first line are trying to, especially where there aren't specialists that they can refer to. I don't know if this came up in the research or if, it's more of a what to do about these things. So just curious if that was discussed at all.
So what is your question? Is it
what
is
is
the
brought
status of
up, I
primary
guess,
care?
yeah, the status of primary care, and again, it goes to like the fixing of the issue, I guess, but
Yeah, so
I guess percentage of people dealing in primary care in places where it's been successful are higher life expectancy, et cetera.
yeah, I mean, I think it lets you say, what are the problems people are facing? I mean, what is primary care, right? It's not, how broad a brush is it? What does that mean? Is that someone dealing, what should people be trained in if they're facing primary care patients? Should they be, we need to make safe birthing conditions. This is our big issue. Okay, this is global health. We're going to Rwanda. We need safe birthing conditions, safe birthing conditions. We're going to Haiti. Safe birthing conditions, safe birthing conditions. Great. Okay. But what if women aren't dying in large numbers in childbirth? And what you need to be able to do is diagnose cervical cancer. Or they're having a host of road traffic deaths. deaths. Or you have children, basically the issue, I talk about this in the book over and over again, is there's this sort of tacit assumption that if you save a child, if you stop child deaths, if children live past their 5th birthday, then they magically grow up to be 85-year-old Norwegians, right? And so there's a lot of forking paths from that. And child survival rates have increased 70, 80% in the last 40 years. But teenage 20-something survival rates, especially for men, have only increased about 10, 15%. So you have many more children living past their 5th birthday, but then they might be dying of suicide, violence, car accidents, cancers, heart disease, or increasingly, issues like diabetes, cancers. And so, I talked to Paul Farmer for the book, for example, very famous Partners in Health, operating in 12 countries around the world, and he was just, it was just like cancer. We need, we've got all these women with cancer, they're not being addressed and they're not being diagnosed, and they're going to have, or people with trauma, they're not having trauma surgeries. So it really, again, I don't want to just say this is the one side, this is like what primary care should be. I think it depends what your issue is, because there are certain countries where women are still dying of heart numbers in childhood. So, and in this country, I think you'll also find that at a county level, what people's issues are, or even at a St. Pat's versus community versus partnership level, what are the health problems people are facing. So, I don't know if that's satisfying or unsatisfying. We can talk more or dive into it at a county level, but even to know what questions to ask, what people, specialists to have, what people to be trained in, I think sometimes requires that kind of picture, or the picture helps.
We're going to break because it's 8:30. It sounds like you're happy to stay and talk to.
Sure. I can show you if you guys want. If you have a specific question or you want to look something up on a tool, I've got the web pulled up so you could divvy it for any particular place you're interested in.
So I'm talking about